I am. All right. We'll get cooking in just a minute. We have got a ton of folks coming here. Rob, pretty crazy.
Good.
Yeah, we'll have a good time. So welcome everybody. The early birders are here. The folks that are hyper organized are winding up in here first. It's great to see everybody. All right, so the question of the day, here it is. Question of the day. First of all, where are you from? And who is your favorite sports team? If you don't have a sports team or you don't like sports, just say, I don't like sports and you guys are nuts. That's okay. But if not, who's your favorite sports team? And anybody from Pittsburgh, just saying. Anybody from Pittsburgh? You got to love that rivalry with Pittsburgh. All right, from Jalen's from Montana and the Cubs. Oh, there you go. We got, who is that? Is it Melissa? Palo Alto Ravens from Baltimore. She's from Baltimore. All right. Man, Tampa Bucks for Tom Brady. Robin, how are you going to argue with that? Right? Cannot argue. All right. Vermont, the Predators. Okay, fantastic. Texas, Denver Broncos. Buffalo Bills.
I'm going to go New York Giants, even though I'm from upstate New York.
Yeah, that's all right. You can do that. You can do that. Atlanta, so the Saints, hello, still the Redskins all the way from PA. That is not politically correct, Leah. It's Commanders now. All right. Don't like sports, but Muhammad, that's okay. It's okay. You don't have to like sports. We're not going to judge here. All right. Not a sports fan from Georgia, love it. Texas Rangers and the Dallas Cowboys from April, love that. Martinsburg, Virginia, the Cowboys, Chicago White Sox. So for those of you who are just hopping in, where are you from and who's your favorite sports team? And if you don't like sports, that's okay. You can let us know we're a bunch of losers for liking sports. You can say that too, right? Right, Rob?
You got it, baby.
Honda's got the White Sox. Stephanie's got the Gators. Jerome from Elizabeth City. Is that Elizabeth City? North Carolina. Gotcha. The Cowboys. Love it.
There's my Giants fans chiming in. All right.
There you go. Martinsville. IU. Is that Indiana? Is it Indiana? I guess it's Indiana University. Memphis. Titans. Of course. Belinda.
Duck Bears.
But Dahlia. I'm sorry. I mispronounced that. All right. So those of you just coming in, where are you from and your favorite sports team? And if you're from Pittsburgh, we're going to knock you right off of this call. There you go. All right. Rosemary likes the Ravens. Oh, fantastic. There's a lot of folks in here. Canton Hall of Fame football. There you go, Jacqueline. We got Ed Reeves is a friend of the family. So we know a little about the Hall of Fame. Don't really have one from Michigan. That's okay. Christine. Idaho, no team. You don't even have a team. I'm sorry, Donna. That's okay. You don't have to worry about that. No national. They make too much money. Stephanie, you are right. And Simon can stay. Simon likes the Ravens. Texas, of course, the Cowboys, all in caps from Norma. Atlanta, Wichita, and the Chiefs, love it. And anybody, so where are you from and who's your favorite sports team? We'll get cooking in just a minute. Yes, you are just so everybody knows, this isn't a sports talk show. We're at the virtual telehealth patient care monitoring and best practices. That's where we are. But we're just the icebreaker here. We have 83 messages here. Holy cow. Steelers, got to go, Sheila. Sorry, kicking you out.
Be nice, Dave.
All right. Wisconsin, Vikings, love it. From Florida and Oregon now, that's what Stephanie's saying. New York Giants, there you got one from New York. Go from Miami, Florida, go Mets. That sounds like a snowbird. Lillian, sorry. Oh, very good. Ngazi, you got to go too. He's Pittsburgh Steelers fans. Gotta love the rivalry, right? All right. For those of you who want to see all the rest of the Dub Bears, we got Dub Bears from Valerie. Love it. Oh, fantastic. Anybody, you can take a look at that for yourself. Don Howard can stay. Baltimore Ravens, of course. All right, let's see. Any last minute come? Who's the Steelers there? Steelers every day, all day, says Rosemary. Man, oh man, the terrible towels. Oh, fantastic. Yes, this is Thelma. We will get cooking. This is the virtual telehealth patient care. This is not a sports talk show, but we were just asking the question as you're coming in, just to get to know one another a little bit so we can get things cooking. Everybody, you got that? You see this?
Yep.
Rob Coffee.
Hi,
All right,
everyone.
welcome everybody. So that icebreaker question was where you're from and your favorite sports team in the chat is what we were talking about. For those of you who are like, are we in the right place? You are in the right place. We want to welcome everybody, a whole bunch of folks here from the VA. Thank you very much for what you do. A lot of folks here. We have Indian Health, HRSA, CMS. We have folks from across the board, including Justice and some other Bureau of Prisons as well. So we appreciate you guys being here and joining us. And Rob, you're not going to believe this, but people are saying this will be the best briefing ever. If
you don't sing this time.
What's that?
You don't sing this time.
Did I sing last time?
You did.
I did. We're not doing that. I can find out if I can get free internet access for my rural HBPC veterans whom the iPad cell plan does not cover. Great question, right? Because that's an issue these days.
Absolutely.
Marcia, I feel I'm educated and empowered to implement without a bunch of hoops to jump through. I love it, Marcia. Fantastic. George provides integrated patient care approach utilizing telehealth. I think we're going to talk a little bit about that, right? Right, Rob?
100%.
And Teresa, suicide prevention is addressed as a major topic. It is a major topic, is it not, Rob?
It certainly is.
It certainly is. And this is something that I think is one of the huge benefits of telehealth that we can talk about. Troy, I can learn how to increase the use of telehealth by providers. Love that. Amy, I learned something new. Anything new for Amy? Amy has the low bar, just anything new. Tina, we can discover quality improvement ideas for telehealth program, especially related to rural and disabled veterans. Huge issue, right? Rural area, disabled, that's a place that you live really well, don't you, Rob?
100%.
So Jules from CPP incorporates practice guidelines for conducting psychiatric independent medical evaluations. Wow, that's a heavy one. I don't know about guidelines. You know about guidelines, Rob? Or we will be talking about that, though.
We'll talk about the big picture stuff. The guidelines are definitely more practice by practice as a general rule, but we'll talk about it.
And we'll talk about it. Wanda, I'm able to incorporate this information in my daily practice while caring for veterans. We appreciate what you do. All the folks from the VA and caring for veterans, huge thing. I'm not going to try that name. Everybody sees it. Expand role of nurses is highlighted. Absolutely. It's important to have nurses involved, isn't it, Rob?
Yep. Well, that's a big part of it.
That's right. And how to order telehealth for seniors. Our telehealth cancels many consults if they have trouble getting the patient on. Big problem dealing with elderly, right?
It led to a lot of what we do.
Yep. Marine, you can send food. That's up to you. DoorDash. All right, fantastic. Jeanette, begin the learning process of telehealth. Fantastic. Somebody that's new. Nicole, content is well delivered. All right, Rob, well delivered. Has to be well delivered.
That's on you.
And with the VA says, give practical intervention strategies for managing elderly with chronic disease. Love it. We'll talk about that. And Richard, again, help us prevent one suicide or homicide. Man, Richard, and who was that talked about suicide in the previous one? Troy and Richard, obviously big deal, especially with the VA and helping the vets. Thank you for doing what you're doing. No, it's a big problem. And hopefully you guys can chime in on that as well. We appreciate what you're doing. Please address, Marianne, challenges with education, equipment, procurement in the elderly. Imagine that, Rob.
Again, that is one of the main, that question is at the core of what inspired me to be doing what I'm doing today.
That's awesome. Kelly, cost of home telehealth, who can prescribe home telehealth? Love that. That's process oriented, but also having the right stuff. Luisa, has there been a problem involving the older population with telehealth programs? Any equipment for the elderly? Wow. Hey, are you ready for that one? Are you ready for that, Rob?
I think I can handle that one. I think I got
That's
that.
that's the big, Luisa, you have the biggest softball of the day so far. Kim from HHS, how to achieve face-to-face requirement in rural healthcare locations where internet is not uniformly available. Huge issue, right?
Absolutely.
Wow. Do you have any idea on that name? I'm gonna let everybody read that name next to CMS because I don't know what that, I don't want to butcher it. How will quality of service be measured? Great question. How do you measure that? And then Edmund from the VA, what can your platform do to monitor sleep disorder breathing? Great question. Is that in your wheelhouse so far?
Yeah, the last one is something that, we do a lot with cardiac and cardio monitoring, stuff like that, but I haven't really thought about the sleep monitoring aspect of that. But I'm going to have to look into that one.
There you go. So we got some of that. A couple more here, and then we'll get into it. So Victoria, lack of internet capability, cellular signal in rural areas, again, inability of the elderly to follow instruction or operate equipment.
Feel a theme here.
Jolena, recommendations for increasing virtual telehealth use by providers or more resistant patients. Wow, if that doesn't just describe both sides of the coin right there. Maureen, what improvements will be in place to improve the significant delay in home supplies and equipment vets need for home care? Wow. Yes. I don't know that we're going to address that today, Maureen, but this is, if you think about it, hopefully the ability for that patient communication and then running that up through the food chain would help. Sadie, what measures are taken to ensure connectivity in remote areas? Well, a lot of remote areas. All right. So, well, the first disclaimer that we have today, and I'll get to this disclaimer in a minute, is Rob Coffey and everybody else in his office, HIPAA violation coming, is COVIDized. You're COVIDized right this minute, aren't you?
Right this minute. So bear with me as I'm a little bit slow to respond.
Yeah, so give him a little grace if he's not operating at 100%, because if those of you that have COVID, I've had it. I think just about everybody has had it. Give him a little grace today. He woke up. He didn't want to not show up because I think there's 700 and some odd people that are registered for this particular thing. But you're not going to believe this, Rob, but this is not endorsed by GSA or any other agency. GSA makes us say this. All the participation in the briefing is voluntary, and engagement by you, government personnel, is not an indication to or endorsement to commitment to purchase from any vendor. And that way you guys can participate. In the session docs, you will get these momentarily in the chat. It'll have the briefing presentation, presidential executive orders and memos, NGA telehealth memo, and the VA national strategy for preventing veteran suicide. Huge for Troy and Richard earlier. We were talking about that. Big time part of the reason why telehealth can be utilized. So here, if you've never been to a Zoom before, you can go up and click up the top and use that little doodah, very scientific term, to make us bigger or smaller. We love participation, don't we, Robert Coffey?
Absolutely. The more the better, because the more you participate, the less I have to talk.
That's right. So with that, we have docs that are going into the chat that you will see where you can download all those things. Because we have so many folks, let's do this. Raise your hand, pop it in the Q&A. We'll make sure that we can dialogue. We love the dialogue. And if you have something that you don't want the rest of the world to see, send it to rob.coffey@cometmd.com, and he will do his best to answer any questions that you have. So the first thing we're going to do is we're going to find out who in the world is here and why did they decide to join us today. So first of all, you're in telehealth management looking for solutions. I'm a healthcare provider and want to know how to do it. You may be in healthcare administration. Maybe you're in procurement and you want to figure out how do you know who has good stuff. Or my boss made me come. And there's many as you want. And we know we have Weisenheimers that are going to pick my boss made me come. And then, is this your first Gov Brief? Fantastic. A lot of folks, it's their first time, Rob Coffey. We love that. And we really want to make sure we get to where you want to go. So while they're answering that question, tell us a little bit about CometMD. You mentioned that you got into this primarily from the senior side of things. So tell us
Yeah.
Tell us what made you create this whole thing, and then we'll talk about you a little bit more.
So I had before I was involved with Comet, I had an in-home senior care company, and we would go out and thanks for the Go Vols there down in the chat. Had an in-home senior care company, and we realized that of our elderly patients that we were taking care of, and we did non-medical senior care, to be clear here, we realized that these folks were just not getting good, consistent health care.
Mm.
They would have, a chronic issue like heart disease or high blood pressure or whatever, any number of things, and still only get like a normal, once a year, maybe twice a year visit with their doctor. And then when COVID hit, they were even more, less access to healthcare. So there was just a huge gap of getting these people a better quality, higher level of care. So we thought, how can we fix this? Of course, telehealth was one of the first things we thought of. Makes sense. And remote patient monitoring, everyone had iWatches, and there's all these different devices that you could buy. And we thought, cool, we can just kind of aggregate some of that stuff. And then we ran into all the things that were popping up in the comments. We thought it was going to be an amazing idea. And then we realized that a lot of the seniors weren't tech savvy, didn't want to have anything to do with it. They would not even have Wi-Fi, wouldn't know the Wi-Fi password just to start with, never mind getting deeper into how some of that technical stuff works. So we kind of took a step back and said, okay, let's design something specifically for elderly people that is super easy to use, kind of comes as a pre-made package where they don't have to hook anything up, they don't have to pair anything, they don't have to sign into anything. And then we made the user interface extremely streamlined, and we'll talk a little bit more about that. But long story short, we came up with a platform that eliminated all of these things, these issues that they kept having where it was too complicated to use, they didn't understand it. We built in the ability to have either cellular or Wi-Fi. So for these people that have, are in rural areas that have don't have great cell phone coverage, first of all, we have several different cell phone providers that we work with, but our platform works on both cellular and or Wi-Fi, either one. So it's the broadest range of coverage that we can get them. It's a turnkey. Basically the way it works, they get a box, they open it up, they literally turn it on, and they can start using it. All they have to do is know how to, just like they would do with a cell phone, plug it in and turn it on. Only, and this is in our platform, at least, there's only 3 buttons on the front, and they all are like, do this, do that, and do this. It's as easy as it gets. They can't accidentally turn off the camera. They can't accidentally turn off the microphone. They're not going to get frustrated because they can hear you but not see you. And we get rid of all that stuff.
And so, and when did you start this thing?
So we started it in 2017, and we had it up in development, and then we really got rolling just before COVID actually hit. That was just kind of when of course, the need for it grew a lot more then.
Sure. And for those of you that are in procurement, small business, you have your GSA contract. Congratulations on that. I know that's no small task in and of itself. And then you work with socioeconomic partners because you guys are small, but you have other avenues that you can do. So I appreciate that. And we'll talk a little more about what you're seeing in the market, because it's not just the product side, but what you also have in the services side and what you see from services. I think that's really important. One of the reasons that we're here is because we have presidential executive orders and other types of initiatives that are coming down. First of all, 13941 to improve healthcare. Well, look at that. Second bullet, improve rural health access, right? You have that. We also talked about telehealth, the first bullet, and make permanent the policies that improve accessibility and availability of telehealth. Why? Because COVID illustrated to us that we can. Mm-hmm. It was a requirement, number one, because we couldn't get together. And then a nice thing that came out of COVID, if there is such a thing as you sit there with COVID.
Yeah.
By the way, for those of you who are just joining us, give Rob a little grace because he's got COVID right this minute. There's nobody in his office because everybody else has had it and wound up some super spreader came in
Pretty much took out everybody.
and gave it to everybody. So the other thing that we know is that the executive order for empowering veterans to end suicide, huge problem. I know Troy and Richard brought this up earlier. So it is a tragic component of our veteran services to have to deal with, as well as, just really want to help that. So that's the executive order 13861. Telehealth can and does play a role in that. And then back in April 5th, the memorandum on addressing long-term COVID effects of COVID-19, not the least of which is the short term that Rob has right this minute. Hopefully it's not long-term for you.
I appreciate it.
So other government actions that we see, the National Governors Association, and there were some issues and questions about different states, right? So all the different states have problems being able to enact and enable telehealth. I saw one from Alabama earlier, as well as I was looking through some of the notes of folks coming in, because some of the laws prohibit it. So what we're trying to do is, and the National Governors Association is working from the state level, the feds obviously working through the VA and other agencies to coordinate this so that the deliverability can be done, and it can be done with privacy at the top and confirmation of making sure that patient is actually who they say they are, and the rest of the components that are necessary to facilitate. So again, NGA is working on this. We're not going to spend a whole lot of time on that.
Hey, Dave, let's wrap up that poll. It's still in the middle of the.
Oh, shoot. I'm sorry. Let me end that poll. There you go. Oh, let's share that poll while we're sitting here. So we have 25% in telehealth. Healthcare providers, we got 45% of folks that are healthcare providers, administrators, a few folks from procurement, and Weisenheimer's my boss made me come, and 92% are here for the first time. Welcome aboard, ladies and gentlemen. All right, fantastic. We appreciate you joining us and letting us know about that. Thanks for letting me know, Rob. We were already down in the rock and roll phase. Speaking of rocking and rolling, agencies on the move, a lot of folks here from the VA. Broadening telehealth is part of your national strategy for preventing veteran suicide. Very important part is that dialogue and being able to reach veterans where they are in the moment, right? Isn't that the whole idea? So with that, we also have the FCC. You're probably saying to yourself, why in the world is the FCC even concerned about this? Now, you know about this, Rob, because it was happening right down in your backyard. And in fact, is one of the contracts that you actually won. So tell us about this, what's happening in Knoxville, Tennessee. What happened there?
So we didn't win the contracts.
Okay.
But this is something they awarded to some people that were in our area, and it was interesting. We got purchased, some of our stuff was purchased through people who got that contract.
Gotcha.
But so Covenant Health here in Knoxville was awarded almost $1 million to purchase a telehealth infrastructure. Cherokee Health Systems, just down the road from us, same thing, almost $1 million to get mobile connected devices to remotely monitor their patients. And it was, government money that they really felt, how do I put it? The need was out there, and they really wanted to help these people get served better because they see the value in that.
And I think it's interesting to see that it's the FCC obviously was going down the vein of how is it going to be communicated, right? So that's what their play was. And then being able to provide that information back into the circle to be able to communicate. And so I'm going to ask the rest of the folks, what is your experience with telehealth? We're going to ask a couple of these questions as we go, just so we understand where you guys are, number one. And oh, by the way, we're all on the same path, right, Rob? We're all trying to solve the problem.
For sure.
So what's your point? What is your remote patient monitoring, virtual visits within specific medical specialty? And you can choose as many as you want, by the way. And a pilot within a facility, or implemented throughout your organization. And then how did it go? Excellent. Patients struggle with technology. I wonder if that's a problem. And physicians practice struggle with the technology. That's the other side of the coin.
Yep.
And back-end integration or a total train wreck. No total train wrecks yet. Oh, that's fantastic. A lot of folks are saying it's working well. Look at that.
I'd love
And
it.
so,
Love to hear it.
yeah, that's fantastic because that's it. So, and
And
then
I
I'm
think
gonna,
it's not just, I think all of us in this space are really starting to realize that the key to making this whole thing work was it has to be user friendly on both sides for both the practice and the patients.
yep. And it, because if it isn't, it's not going to work.
Absolutely.
Because
They're already,
one,
the practices are already overwhelmed with what they're doing. I mean, overwhelmed and underworked, and the last thing they want to do is argue with more software that they don't understand, and it's overcomplicated and all that good stuff.
so we got a couple things here. Janice is saying, if I learn something new and the briefing remains interesting, so stay interesting, Mr. COVID man.
Doing my best.
All right. Let's see what else we have. Is a presentation slide deck available? Yes, it is. Jules, that is going to be popped in so that you can download it right this minute. You can go check the chat right after I just said that, and it should just absolutely miraculously appear if you haven't already seen it. And then how do I get a telehealth job in the VA? Great question. Is that Gannett or Jeanette? I don't know the answer to that, but if anybody knows of telehealth jobs, pop that into the chat as well. I'm sure that Jeanette or Gannett, however I say that, Amante, I could probably say that easier. So there you go. And the rest of these people are talking about their sports teams. So we're gonna just bypass those. So we're going to close those out. If you have any other questions, that'd be great. USA Jobs, search on USA Jobs. Patrick and Chantel said both, usajobs.gov. Love that. Don't you love it when people have answers that you don't have, Rob?
Love it.
Gotta love that. All right, so where's that link? Do we have the link for in the chat for all the handouts? Let's pop that in again. Oh, that was there. Terry did it. Oh, there you go. You
We just had someone in the chat said when they clicked on the link, it asked if they wanted them to leave the meeting.
Don't do that. Whatever that did. Don't leave them.
Whatever that, don't do that.
All right. So we're going to end this poll now. Let's look at this real quick. A lot of folks have almost half remote patient monitoring, 65% virtual visits. Love it. Love it, love it, love it. 10 folks with a pilot. Love that because we're going to talk about a pilot in a minute. And all right. And for the most part, it went okay, right? Some folks said, and then we did have patients struggling with the technology and physicians struggling, right? So
sure.
We know that that's an issue because of what everybody was talking about when we came in here, right? All right, fantastic. Did I stop that? I did shut it down, right? And yeah. USA Jobs, that's great, Robin. Thank you very much. And it will say telemedicine or telework. Thank you, Robin. And for everybody else that was helping folks out, really appreciate that. All right. So what are some of the challenges that you're finding? So there's a study with JD Power. Tell us about how this worked, because this is one of the things you were talking about.
Yeah, we've pretty much already, we kind of glossed over this, but JD Power did a study and they found that while the overall use of telehealth was going up, patient and doctor satisfaction both were declining the more we went through COVID. The more they were forced to use it, their satisfaction level with telehealth dropped. And it's a direct result from all the tech stuff we talked about before, being overly complicated, connectivity issues, didn't understand it, accidentally muted the camera, all that stuff. When the satisfaction rates dropped though, and that was a big kind of an awakening to most of the people in our space going, what is going on? What are we doing wrong here?
So this may or may not resemble my immediate relatives.
That's a good one.
That is a good one. So for those of you who we know that this is an issue, and there's generational issues, but there's also just practical issues, right? We talked a lot about connectivity, but in dealing with seniors, this is an issue. You can't just give someone something and say, okay, this is how it works.
Right.
So there you go. So if you're talking about overall, now we'll talk about what you know, but this is an overall. Here's what you want your virtual care platform to do, right? So the goal of your remote patient monitoring, and we'll talk about that a little bit more, but this is what it has to do, no matter what system you choose, right?
Absolutely.
So minimizing the impact on the facilities, meet the need of the patient, but minimize the impact on facilities. We're just talking about both sides of that, where you need to meet the patient's requirements, but you can't saddle your physicians and your nurses, right? That's a problem.
Sure. And they're already spending so much time doing administrative stuff like paperwork and files and records necessarily. But, that's another thing, I guess I would say that's one of the things that we built in as a best practice into our system, at least, was trying to streamline as much of that as possible. They can even, like, if they do a virtual telehealth visit with our system, it gets transcribed and the transcript can go right into the EMHR, an actual transcript of the visit, both sides of the conversation.
Sure. Hang on one second. Holly's asking, can I see the results of the slide? How did it go? Yep, absolutely. How did it go? Just scroll down a little bit. And I'll stop sharing in just a minute. But Holly, I appreciate that since you were asking for it. And oh, by the way, there was a question earlier about, is this being recorded? Yes, it's being recorded. And you can submit it to the Golden Globes or whatever the heck it is if you think it's just that good. All right, so there you go. Did you get that, Holly? We good to go? Everybody saw that? All right, fantastic. So I did that live. All right, so in with the rest of this, so administrative time and paperwork, you had your integrations, because integrations does have to happen. So you have some IT integrations that have to do with that too, don't you?
I'm sorry, I was reading the comment there, Dave.
Oh, sorry.
What was the last part?
So no, talking about the administrative time and paperwork, right? So there's process integration, there's actually technical integrations too, right?
Yeah, and that's what the comment I was actually reading was tying into what you were saying. Someone there just referenced a Becker's report about physicians spend and their staff spend about 44% of their time doing administrative type work.
And that's overly productive, isn't it?
Yeah, it's asinine. Sorry to say it that way, but it is. But yeah, so there are definitely technical constraints, and there's, everything has to be HIPAA compliant as far as the data flow goes, whether it's digital or paper. So yeah, technically speaking, there is a lot going on there.
Yep. And then vitals, just being able to do your vitals. And this is where you have some really interesting things. I'm not gonna blow your big mic drop moment, but you have some pretty astounding within the pilot and research that you did originally.
Yeah.
Some astounding things about monitoring patient vitals and the impact of that. And then one of the other part is more consistent care. And this is one of the things that you found to be, hey, if it's easier to do and you have the capacity to do it faster as a physician or a nurse practitioner, right? That actually becomes a better way to have more consistent care where they wouldn't necessarily go to the doc to begin with.
And that's the whole, the big punchline to this whole conversation is that done right, it is better care, more consistent care, right? And that's what we're striving for to do this.
Yep.
And that is exactly what, back to the best practices kind of thing. Even if you get one of these RPM systems in a telehealth program, first of all, in my opinion, you have to have one. You almost necessarily need both to do a full, complete, comprehensive, real care of someone. Sure, you could do a telehealth visit, but if they're your patient, the ability to see their blood pressure every day or get it once a week, once a month, whenever you want to get it, and track that over time, and then have one of your nurse practitioners reach out once a week and check in and notice, hey, Denise, I noticed your levels are up a little bit high. What's going on with that? Oh, me and the husband went to Dairy Queen last night. That's whatever it is, right? So just
stop busting on Dairy Queen.
The ability to provide that much more consistent level of care does change lives.
It does. And that gets to direct access to nurses and doctors. And it gives you the ability to identify those critical issues so that you can get to the emergency care. And you can, I'm going to tease it one more time. You have some astounding.
Yeah. And actually that's what I should have caught that, but what we really try to do is not get them to emergency care. We try to get them we prevent them from going to emergency care, period. We want to get there and catch it before they wait 6 months between doctor visits and all of a sudden they have to go to the ER because they're having major issues. That's the whole idea of this, so we can stop that from happening, keep them out of the ER.
But when they need it.
Yes, but when they need it, we can get them to care.
That's the big, so one thing is keep them out of those emergency visits, because emergency visits are the most expensive things you could possibly have, number one.
And system, absolutely.
And I tweaked my ankle in a weird way. And I was thinking, do I go to the emergency room and sit there for 6 hours waiting? So the answer was no, I'm not. So so there you go. So ultimately, bottom line at the bottom line is better satisfaction with the patient so they feel more connected. That's what every patient wants. Every patient wants that.
Every patient wants their doctor. The doctor wants to feel like they are the most impatient that their doctor has, right? That's what they want.
That's exactly right. So with that, so we talked about virtual, so the telehealth piece, right? So that's one piece, but you mentioned something that's actually separate, and that is monitoring the patient, which is what the next question is. What is your experience with remote patient monitoring? So physician recommended and prescribed? Is it patient-owned device like an Apple Watch or Fitbit or whatever the heck? And then physician supplied device that was provided by an agency healthcare system, or device that was monitoring and healthcare professional were provided. So there you go. And how easy was it for the physician to get the results? So this is where you start to merge those two worlds, along with it doesn't stop you visiting your doctor, does it, Rob?
No, it absolutely doesn't. Of course not.
No.
That's the idea, is we want to just help get the doctor more information more consistently.
Yep. And that's what we're talking about here. So the remote patient monitoring is different than just the telehealth, right?
Absolutely. Absolutely.
Now, when you pull them together though, right? So
that's when the magic happens.
Right? That's where the magic happens. You're talking with the individual patient. The doctor or the nurse practitioner is talking with the individual patient. You're looking at their stats at the same time that is happening. Now you have true ability to do dialogue and detect things that can significantly save lives. And that's the last tease you're going to get for that, Rob. we promise that we're going to fulfill that tease in just a minute. So this is a kind of a complex question. So I'm going to leave that open for just a minute, and I will get to a question here. Patrick says, is this about a new program that links facilities' existing EMR system? If so, is this program that has been purchased approved by the VA? The answer is no. We're talking about best practices. Now, there are places where there are components of this in play, as you can see right now with the experience with RPM and the different ways that it happens. So when it comes to being approved by the agency, it depends on what the goal is and what is the mechanism. So you have the goals, which should always be the same, right? Which is enhancing your patient interaction with the doctors and being able to prevent things, right? Right, Rob?
Mm-hmm. Absolutely.
And so they can happen many different ways. But then there's also segmentation of the market, because some people are running around with iWatches or other type devices, so wearables, and then other folks that have no concept of any of those things and don't have access to them in some form or fashion, still in rural areas especially, or aged populations. Or we didn't even talk about this. What about the disabled vets and other disabilities, right? Where you don't have the ability to operate a regular piece of equipment. So that's another place to play that we can talk about. So that one of the questions. So the answer is that it's best practices. And yes, some of those are approved by the VA and some of them are under the process of being approved. All right. So Denise is saying, in RPM HD, the RN care coordinators provide timely biometric data to the veterans primary care team or specialty team. That is true, right?
And that is something that we do as well. Yep.
Exactly. That is exactly right, Denise. Great comment.
We don't try to take over being their primary care. We just try to add to their care level.
So Luisa is saying, we also have noticed the providers get on the telehealth visit and after 5 minutes they hang up and mark the veteran a no-show. Then us nurses get the complaints about it. Imagine that. I can't imagine that, Luisa. That's
Sure.
exactly what happens.
So we have, and kind of to address that, we ran into some of that too. And, unfortunately, some people are just going to flake on you, but we also have the ability where if they don't call in, you can actually call their tablet or you can call their device from your telehealth platform.
And see how that becomes the two-way, right?
Absolutely.
Because it isn't necessarily controlled by one or the other. Both sides have the ability to communicate.
Right.
And that, ladies and gentlemen, is exactly why you won't have those types of things, especially since those little pinging reminders can come. All right, we're going to end this poll in 5, 4, 3, 2, 1. And let's take a look at it real quick before we jump into the next one. So physician recommended, just about split. Patient-owned device, right? Almost no physician supplied devices. Wow. And then we have the devices provided by the agency, right? Love that. And the healthcare professional, right? The monitoring and healthcare profession were provided. So it's both sides. This is something we haven't really dove into too much, Rob, is that now, in addition to that, you could also have the services associated where you can either do triage first level, or you can actually have the interaction from a psychologist or an MD or whatever it happens to be, right?
Yep, or multiple psychiatrists. I mean, yeah, all of that. Absolutely.
And so getting back to the suicide piece, this is where that dialogue and the escalation procedures, because you already have this baked into your processes along with, so it's services and the equipment itself can also be done. Love it, love it, love it. And look at that. 15% patients had to mail or email or fax, right? And then, or the patient had to bring the documentation. So that still happens, right? But look at that, 72% the physicians have direct access. Is exactly what we're talking about here. Love it. Fantastic, guys. Thank you very much for that. And here's what we've been talking about, right? We're talking about the remote patient monitoring. The technology is here. The wearables, the apps, all the different connectivity that we're talking about here, Rob, right? So a lot of these folks, and yes, access to medical personnel, thanks to COVID, because without it, we would still be noodling through this in Congress, would we not?
100%. 100%.
But because COVID came along and you had to do it,
we had to come up with a way to get in front of people. Absolutely.
It forced us into it. So thank you, COVID, for that one little thing. That's all we're going to thank COVID for the rest of the day. I can promise you that. And I know you don't want to.
That's all I'm going to thank it for.
And for those of you who just joined us, Rob has COVID right this minute, and he's operating out of an empty office because everybody else there has it too. So, but this gives us, in addition to that, so we have all the pieces for probably the majority, right? The majority of society, which is operating with these smartphones, and we're at least half smart enough to be able to use them. And I'm not saying the people that are on this list are not smart enough. So don't start sending me hate mail for that. What I'm saying is generational differences exist, and if we ignore them, or the economic and the socioeconomic area in rural areas, if we ignore both of those, we're going to miss a significant portion of our society that is at higher risk. Wouldn't you say?
At higher risk. With that, these are the people that probably need it more than the rest of us.
Exactly. So as we look at this, we also have to fill this need. So we're going to talk a little bit about what you're doing, but we're going to get into the best practices. But we need to cover all of society, and especially those that get down to that bottom line, which is technically challenged, and that can be the docs or the patients, right? So we have that. So the approach for Turnkey. So this is where you live. So we're going to be talking a little bit. This is definitely in Rob's lane, right? So we're talk a lot about what Rob, because I'm not going to ask Rob about what stuff that he doesn't do. I'm going to ask him what he does do, and then you guys can ask him additional questions, because that's why we're here. But let's talk about what the telehealth approach needs to be if it's turnkey. Take it away.
Right. So the whole premise is the turnkey part of that slide right there is simply we don't want it to be piecemeal, and we don't want it to be something that the patient needs to figure out, right? From our perspective, they have a primary care physician, and the primary care physician says, hey, you got high blood pressure. That's just an easy one to talk about. We'd like to monitor your levels a little bit more. And, people do that all day. They get up every morning and they take their blood pressure with an old school cuff and they write it down in a little notebook. And then every 6 months, they take that notebook to their doctor, or once a year, whatever their plan is. And it gets kind of reviewed. Where the new approach, this whole turnkey thing, we want to send them a box that they put this cuff on, they turn it on, and in the morning, they're going to get up and take their reading off the cuff and then go about their day. But in the background, the system does all the work, just sends it to the doctor. And even from the doctor's side, all the people that are on their program come in at the backside of the system. It's all color coded, if you will. So if, one morning they get the readings start coming in and they notice that there's 13 people that are in the red, like, hey, we better have someone reach out and call these folks. Or let's look and see if they've been in the red for 2 or 3 days. It just streamlines the whole process, right? Back to the whole, bridging the gap. The gap is the gap between the number of visits they would normally have and getting that information to the doctor more quickly and in an efficient way. We still have, so a little bit about what we do. We offer the hardware and the software for physicians and groups to use. So they can kind of lease the stuff from us and they can do all the monitoring, take care of their patients, etc. On the flip side, we also have another business model where we send out all the equipment to the patients and we do the monitoring. And then we act as an intermediary between the patient and their primary care physician. Right. So that's the service part that we're doing to bridge that gap.
Right. So you have both sides of that. And when you look at what we have in this one, you have to have it has to be HIPAA compliant.
Oh, yeah, yeah.
It has to be smart. All the people of this. But what you're talking about also is the burden of the hardware should be pushed over to the vendor. This is really important because your IT staff doesn't want to do it. I can promise you they don't want to do it. I've talked to enough CIOs and the rest of their staffs in my lifetime to know. And also dealing with the workload for the staff, because you can get and talking about your services, it can be a hybrid. You're actually a hybrid model anyway, because you're not actually you're not the final care provider. You're just helping bridge the gap between that and figure out if it makes sense.
Right. And that has and that has to be, even the hardware. That's part of one of the things about, best practice things that we like to think about. If you're not using a system like ours, where we do where we take care of that whole burden, you almost necessarily have to have someone in your office who only is, the person that responds to tech support and hardware calls. Something like a battery needs to be replaced or a screen got cracked.
Mm-hmm.
If you're not using something, and I know that the VA has systems that do this, but I don't know if they have this part of it.
Yep. A lot of them don't.
When that stuff breaks down, or when there is actually an issue, a burden, that becomes a huge burden because now the patient's readings aren't getting through. They're getting frustrated. As soon as they get frustrated, it's a great excuse for them to stop using it. And that's no good to anybody, right?
Yep. And then also you have somebody mentioned transcripts earlier. So the ability to minimize the workload again on the staff. So there's that part. So we're going to talk about case study in just a minute, especially with seniors. So HIPAA compliant, right? RPM is streamlined for integration to EMR, right? Emergencies, right? Transcribes your visits, huge, right? You were just talking about, somebody said 44% or something like that, right? So the fact that it's cellular based or wireless based, right? So Wi-Fi.
Yeah, and I realize there's probably somebody out there that's going to go, what if they don't have Wi-Fi and they're in an area where they don't get cell service? Well, that's a very rare situation, but unfortunately it is a situation. We have a couple of different cellular systems that we work with. We haven't yet found anybody that we can't get service to, but I'm sure that they're out there.
Yep. And Holly, you're right. There's different, depends on your vision, right? And Holly's saying in Erie VA, we have staff that do all the tech support for the vendors we have now. That's correct. It isn't universal.
Right.
Everybody knows this. Anybody's from the VA can chime in. It's not universal. And we've done enough work with the VA. I know a lot of folks there. Appreciate all you guys, by the way. But so to your point, it doesn't necessarily have to be there, but in this instance, no matter what you got to solve that problem with the hardware and the software and the tech support. And oh, by the way, the physicians can't be on the hook for it, or the physicians' IT components don't need to be worked on it. So let's take a look at this. You did a clinical trial. Let's talk about this case study. This is where that mic drop's coming for everybody.
Yeah, I mean, these people are already in that space, so it's probably, a lot of them are. It's not a huge mic drop to them, but we were astounded. We built this platform, we got it up and running, and then, as I said before, we kind of set it up with 100 people that were in our in-home senior care program. Just gave it to them for free. Said, hey, let us monitor you, and go from there. And we found in the course of, I think it was actually 10 months, we identified 7 patients that had AFib and didn't know it. 7 people. I mean, I don't want to say that we saved lives like that, but I mean, the reality is we more than likely did, because these patients were only going to their doctors once a year. And they had no idea they had AFib, but one of our nurses was checking these readings and all of a sudden said, hey, there's some irregular heartbeats going on here. Let me set up an appointment with your cardiologist, or with a cardiologist for you. And with 7 different people out of 100.
Out of 100. So
that's crazy.
So for those of us who are not math efficient, that's 7%. That's 7%. Right in that trial alone. So this is some of the impact that is so critical. And you think about this from Troy, especially Troy and Richard, because you guys are working to reduce veteran suicide. This is exactly the type of system that will help do that. So
there's a couple different ways just to touch on that, because I'm sure someone wants a direct answer to that. It's a multifaceted thing, but a lot of the times there are medications involved. And if you're monitoring people's vitals all the time, we can definitely see if they are taking the meds, if they're not taking the meds. A lot of that comes into play. And then the other part of it comes into the actual use of the telehealth and the ability to make it a two-way call. And our system also does some things to kind of specifically address that, where we have, and there's HIPAA is involved with all this stuff. So when I say this, I realize the complexity, and we've handled all of that. But we have the ability to contact friends of the patient, family members of the patient, if we haven't been able to hear from them. And we try to make it like an all-encompassing, not just, okay, hey, make sure you come to your visit on Friday at 3:00. Don't miss your telehealth visit. When we're dealing with these people that are struggling with something like this, you really have to be active, and you have to have multi-channels of connectivity and being able to get a hold of not just them, but family and friends with their permission. And that really is, kind of the heart and soul of it. So it's not just that, it's the ability to get out in front of them.
And kudos for solving that, for working to solve it.
We're working it. We just want to
work it. And like I said,
and actually one other thing I want to touch on, which came out of conversation with people that were in the VA, which we didn't even know, but we've now built into it. They wanted to be able to have one patient do multiple visits at a time, to do group therapy. And I was like, how did we not think of this before? But so we built that into it, and now they can have, I think it's up to 40 people in one visit, something like that. And then the flip side of that was, often we'll have someone that had one patient that has such a complex problem, they've got a specialist in New York, and they've got someone in their hometown, and they want to have 2 doctors on one visit with one patient, or 2 doctors with a group of 40. There's a lot of that we learned by talking to some folks at the VA, involved with the VA.
And that's a lot of folks here on the VA, that's you bringing the information and saying, hey, we're having this issue.
Yep.
And that's how real things get done.
Yep.
And speaking of that, the results of the case study, you saved lives. That's just,
Yeah.
how cool does it feel that you saved lives,
Pretty awesome.
man?
Pretty awesome. We didn't, but we got their doctors to save their lives, and just love being part of that process.
That I love it too. And getting back to what we talked about before, emergency medical treatment, great. Non-emergency medical treatment was handled remotely, so they didn't have to go to the ER. This is just as important. I mean, obviously, you want to get the emergency treatment when you need it.
Yep.
But again, the need for turnkey accessibility is exactly there. So, if you're talking about mental health, we've talked a lot about that.
Yeah.
You have physiological symptoms that present themselves in the monitoring components, and then it's streamlined, getting people that escalation procedure that you talked about. If you don't reach the patient here, here's the escalation procedure that is defined by the doctor and the patient working together, so that because their lives are worth saving. 100%. That's why, oh my gosh, these folks they've served the country, and we want to save their lives. So we'll talk about this, and then we've got a couple more questions and comments to get to. But piloting a turnkey telehealth, it's very simple. Choose the patients, right?
Right.
That's the first thing. Choose your patients, and then we'll work through the process. And it can be done through simplified acquisition, and it can be by provider or administrator-led operational within 30 days.
Yep.
So that is one of the things that we're going to be talking about in this next poll, which is you want to continue the conversation. There's currently we're working on, you guys are working on this, which is, I need help with meeting the telehealth initiatives. You like to discuss a pilot with comment, and you like to discuss a demo with pilot, either one. And then, if you want to be a panelist on the next telehealth briefing, we would do this again, because we had over 700 people that said that registered for this. Obviously, a lot of them couldn't come because they're busy with patients, for crying out loud. And then let us know. And then if it's an immediate budget requirement, there's things that can be done right away. Obviously, we have the budget coming up, and then in the next 30 days, whatever it is you want, we want to make sure, obviously, if it's budgeted or it's very important, then pick that. But otherwise, we'll do this when you guys can. Right, Rob?
Absolutely.
All right, let's get to the rest of this. While we're here, I had a couple of comments that were in here. One of my comments was, it's not universal in VA. And Richard says, when you've been to one VA, you've been to one VA. That's because that's how they operate, right, Richard? That's exactly right. And Holly was talking about it, take a huge burden off the staff where they could focus on other patient care and support tasks. That's exactly right. The objective is to streamline it. Doesn't matter. Just, we know that each system has its own benefits, right, Rob? Right. Yours is not the silver bullet, is it?
No, that's the whole thing. It's everything they do really has to be streamlined out of necessity, not just telehealth or every single activity that they do in their offices throughout the day, because they're trying to cram, what is it? I think it's 4 an hour now, 5 visits an hour, something like that. I mean, it's just staggering the number of people that they have to see. Yeah. Right. So anything we can do to make the process simpler is what we have to do.
Yep. And that's on the patient side, and that patient satisfaction component that's the piece that we're looking for, is patients. I'm a patient. I'm not a doctor. But when I go to the doctor, I want to make sure that we get to where we want to go. And the question was, who's the best point of contact? When we get ready to expand these services from Shannon, boom, rob.coffee@cometmd.com. Reach out to Rob.
Please do.
So, and Christine's saying group visits can be done with the VA system. There are processes in some instances, right? And through VVC, absolutely. And you're welcome, Susan Keefe. She says, thank you very much. It's very informative. So you did the informative one. So is this being offered to the VA? Yes, it is being offered to the VA. There's pilots that are being created right as we speak, and you can pick one right here. Is this whole presentation sales and marketing thing? No. It is about best practices, which includes products that you may need to know about, because that's the way it works. All right. So, and Janet, I'm not in a patient care setting that utilizes virtual health or patient care. Thank you all for the informative. You're welcome, Janet. And let's see if we got one. Do we have any more within the questions and answers? And Vicky Lynn, what a cool name, by the way. I'm unsure where this is going so far. I'm being told information I'm familiar with. Please identify the purposes besides obtaining big data. It is not just about big data. It's about serving underutilized, if I can synopsize this for Vicky Lynn, serving especially rural areas. A lot of folks have the question about rural areas. So that may not apply to you, but there's a subcomponent of the patients that you serve that is also in the technically challenged. Wouldn't you say, Rob?
Yeah, and to take it a step further, we're trying to kind of get the point across that whether you use our system or someone else's system, whatever it is, I think to bullet point it, you have to be trying to pull off just telehealth or just remote patient monitoring. For one, is kind of a tough thing. You almost necessarily need to do both at once from our experience. And it's more than just the technology that you're using. You need to have, it's the touches from the doctor and the nurses that are the most important part of this, right? I mean, you can get any system you want, but if they're overwhelmed, but if the doctors and nurses are overwhelmed and it's not getting used, or if it's too complicated and not getting used, then the whole system is, kind of redundant and pointless. So it has to be a streamlined, easy to use system. And you have to have the practices in place where your doctors and nurses are touching the patients enough times. I guess touching isn't the right word considering we're talking about virtual visits here, but I think everyone gets what I'm saying, right?
Yep. And the end, so Janice is asking, is the software that will replace VA VVC? Probably not. It's probably going to be used in augment. What we're looking at in the pilots that are being scheduled now, augmenting that system to help with especially seniors, if I can just surmise it, seniors,
Right.
Rural communities and such, and disabled, right?
Yep. And
I'm answering some of these for you, Rob, because I know you got COVID.
And they're going so fast, I'm having a hard time keeping up with them. I'm trying, and I appreciate you doing it. I did see someone just said something along the lines of, do they supply iPads? Yeah, our system works. When you get the tablet and the tablet is part of the deal, part of the package that they get. But the telehealth you can also do without the tablet. They don't need that to do the tablet. They do need the tablet to do the remote patient monitoring piece.
Yes, that's true. And Robin has to go. She said, great discussion. We made it fun and informative. There we go. We did our job. All right. Appreciate that. And so we're going to get you wrapped up and get out of here. We'll answer any additional questions. Real quick, I mentioned it earlier that you don't have to purchase from any vendor, including CommonMD, but if you'd like to, information is there and supplied for you in the presentation. By the end of the day, you will get the briefing presentation. You'll get links to the session docs as well as the video that you can share with some of your other folks if you want to. And we are also making sure that you have the ability to connect with Rob one-on-one to discuss things if you'd like to. And there's Rob Coffey.
Yeah, please feel free to reach out and I'll be happy to answer any questions and see what we can do.
That's right. And so there you go. Thelma says, thanks for sharing your knowledge and insights. Signing off.
Thank you,
I appreciate that, Thelma. Awesome. And everybody else, we appreciate you guys. VA folks, especially, thanks for what you're doing for the veterans. Not that the rest of the folks at different agencies aren't important. Man, oh man, some of the things that you guys do every day, we just thank you so much for what you do for your support for the vets.
Think about respect and admiration.
You better believe it. What agencies are included in this meeting? From what I remember, we had Indian Health, we had Department of Justice, we had Bureau of Prisons,
EMS, HHS.
That's a great question. Let me go back to the original one. Let me see what I got here. I'm gonna pause this so you don't have to watch this whole
And
rigmarole.
we'll try to get back to some of the questions that are popping up. I'll try to answer offline or shoot you guys emails or something after the fact.
Yep. Hold on a sec. I gotta go back. It won't let me go back. So let me go back on all these slides. I'll go all the way back to the original first ones, and I'll tell you exactly who came from the different agencies, and that is bam. So those are the folks that wound up coming to this.
Hmm.
So there you go. So there you go, Julie. Hopefully that helps. And Vicky Lynn, we'll get in touch to talk about the solution. So help serve. So Holly's asking, how does this additionally help serve those in rural areas that can't use technology now because they have no service from any data provider? Great question.
And again, that's the one thing, you know, we'll try different cell companies to see if we can get a cellular signal. If not, hopefully we can get them hooked up with internet. We actually, I just remembered this one. We actually have in one of our pilots now, we're dealing with someone who is homeless. And we ended up getting a tablet in their hands to help monitor them. And they go to not that I'm asking your patients to do this, I'm just saying how some of the unique things that are out there. They actually go to a McDonald's every other morning and use the free Wi-Fi to get their readings sent back to us. Pretty cool stuff.
So again, Holly, you're never going to solve all the problems, but if you get creative about it, either McDonald's or libraries, right? So there's another place that you can go. And I'm not sure, Marla, that's my same question, but hopefully we answered it, whatever that question was.
Someone just said satellite internet. It's not a satellite internet. It's just cell signal. Verizon, US Cellular, the big carriers who we try to use.
Yep. Yeah. Satellite. Yeah. It's common. Colby's talking about satellite. That's probably why you're talking about it.
Yeah.
Colby's talking about satellite internet. It's coming, and that'll help. That will help.
Oh, I'd love it. I'd love to get Starlink hooked up on all our stuff. That'd be crazy.
Darn right. Yep. So there you go. Fantastic. So, well, we really appreciate you guys. We don't want to hold you anymore. We're a little bit over. If you have any questions, shoot them over to rob.coffee@cometmd.com. And if you have any issues or you want to talk about GovBrief in any form or fashion, support at govbrief.us is how you can get in touch with me or anybody else on my team. And we'll be glad to help you guys any way we can. We appreciate you all. You're welcome, Sarah. You are welcome, Amy. And really appreciate
well wishes. I appreciate it as well.
And yeah, there you go. And dude, you're a rock star. And for those of you I know Rob a little bit because we've been dialoguing as we're preparing for this. And I can tell you, he is not operating 100%. And think about this. If he operates like this under COVID, can you imagine what he's like at 100%?
I appreciate it, Dave. Thanks, buddy.
There you go, man. Go get some rest, my man.
Thank you all, and look forward to talking to you.
Yep, we appreciate you guys. Have a great rest of the week, and rest of the summer almost over. Good grief. Oh man, can you imagine? I don't want to talk about it. I'm getting depressed.
I don't want to talk about it either.
All right, Rob. Thanks.
Bye, guys.